طيب والمؤكد انها will become more popular by. انا هقدم لكم كل شويه هنتربط لو انت تساعدني، نتربط بس نقول كلمتين لو في حاجه مش مفهومه. ابتدي بقى حالة بلد. We start our first case in Egypt of renal artery denervation. We are very pleased to have Dr. Simon Sakri with us. He's an expert in this field, and we had a lot of discussions before doing the case. A lot of interesting informations we have received from him. I hope during the live transmission we'll be able to get more and more information about how to prepare the patient and what to do exactly and what are the sites of injections. I'll try to ask some questions during the work so that everyone will be with me in the work. So our case is a 53-year-old lady. She has a positive family history of hypertension, a very strong one, and she's diabetic. She's also a smoker. Since now about 10 years, she's been receiving a lot of antihypertensive drugs. Most of them were not controlling her blood pressure, and during the last 6 years, she has been a frequent comer to the CCU with attacks of severe hypertension. One of them was accompanied with dizziness and encephalopathy, and she's right now on 5 drugs. And as you know, the prerequisites, as in the Simplicity trial, that the patient should be receiving at least 3 drugs, including a diuretic, and her systolic pressure, if she's diabetic, should be 150 or more. This patient has a 170 pressure with 5 drugs, including a diuretic, an ACE inhibitor, a beta blocker, an alpha blocker, and an alpha methyl dopa. I think she fits the profile, and I hope Dr. Simon will tell us what he needs from the patient before deciding whether she's fit for the procedure or not. What investigations we want? What do you think?
It's very useful in patients like this to exclude any obvious secondary cause for hypertension. You can do a whole range of investigations, or you can do, and each centre, each hospital will have its different way of investigating to look for secondary hypertension. Particularly in a patient like this who's had episodic extremes of blood pressure, it's useful to do a 24-hour urinary catecholamine, a screen to exclude a pheochromocytoma, and probably, certainly to do at least a renal ultrasound to see whether there's any sign of renal artery stenosis. And then it'll vary in each centre, but in my particular practice we do CT scanning of the renal arteries, of the kidney and of the adrenal glands as well, to see whether there's any sign of adrenal adenoma. Bearing in mind that adrenal adenoma can be an incidental finding in patients with gestational or essential hypertension. But the facts are that most of these patients will have genetically determined hypertension.
بس اقول اللي بيقوله عشان صوته مش واضح قوي، هو يعني بيقول زي الستبس اللي قالها الدكتور سامح بالظبط، ان انت once you have this kind of severe hypertension you should exclude secondary hypertension. وقال معلومه طبعا على طبعا لينا الدوبلكس مش عارفين الارثروزس ده لازم تعمل ابدومين سي تي ابدومين عشان تشوف الادينوماس، رغم ان وجدوا ان حوالي 20% من البيشنتس 10% essential hypertension اللي عندهم adenomas مالهاش علاقه بالهايبرتنشن. There's not always a direct relation between adrenal adenomas and hypertension. المهم once you exclude this بيتعمل سي تي
and which have been resistant to their medication. But 5 or 6% of them will have some form of a secondary cause for hypertension. There is an argument in Europe at the minute as to whether these patients should be put on spironolactone before they are diagnosed as having resistant hypertension, and that's one of the discussions that we had earlier. I think spironolactone is a very reasonable choice in women and is often very well tolerated in women, but in men get a lot of side effects from spironolactone. I think to have a patient on a 6th or even a 7th antihypertensive can be very difficult, and compliance will often be an issue.
Most of the time, right? 30 degrees would be.
Yeah, it's been 32 millimetres.
32 millimetres.
It depends how the blood pressure's been measured, smaller branches come off. It's very important to be aware of where the adrenal artery arises off and where the urethric artery artery rises off as well.
Yeah.
The consequences of ablating one of the smaller arteries could be potentially problematic for the patient.
But you can see from here that the pressure of this patient is very high. She's receiving 5 or 6 drugs. I mean, this is the kind of patient that really will benefit from such a procedure. What do you think?
Pressure اهو بتاع 210.
Yes, it's the data seems to point towards the higher the baseline blood pressure, the greater the benefit the patient will get from the procedure, which you would...
It's up to 30, I think, right? 30 degrees at least.
Yeah, it's been 32 millimeter mercury.
32 millimeter.
It depends how the blood pressure's been measured during the follow-up, and if it's an office blood pressure, just a single one-off reading,
Yeah.
or whether it's an ambulatory 24-hour blood pressure monitor, then the data has been different for each of those two methods of measuring it.
Yeah.
The aortogram is very useful to see what the takeoff of the renal arteries is like, which has some bearing on guide catheter selection. Once we've had a look at the aortogram, we can talk about the guide catheters. But occasionally, the CTs can be misleading. It can miss small vessels. In my practice, we started applying using MRI scanning, and the MRI scanning missed 2 patients with fibromuscular dysplasia. So I think it's important to also get some form of contrast imaging of the vessels as well. Additionally, you get an idea of whether there's a lot of aortic tortuosity. If there's a lot of aortic and a lot of iliac tortuosity, then guide catheter manipulation can be more difficult. So I like to do an aortogram, but obviously if the patient's got an elevated creatinine or if there's a problem with renal dysfunction, the aortogram is not compulsory, it's just useful.
برضه عشان نبين الكلام اللي بيقوله عشان صوته مش عارف ليه مش واضح فهو بنعمل سي تي بنشوف الاوريجن والشيب اوف ذا رينال ارتريز. sometimes في بعض البرسنتجز بيبقى فيه اكسسوري رينال ارتري و you should know that اذا كان فيه اكسسوري رينال ارتري او لا والسايز بتاعه والتيك اوف بتاعه، لكن هو بيقول روتيني بيستخدم اورتوجرام الاول عشان يشوف التيك اوف والاوريجن عشان تشوز الرايت جايدنج كاثر اللي تخش فيه الفيسل وبالتالي يقدر يعمل تكنيك مظبوط.
As I understood also that the guiding catheters are most of the time are Lima short guiding catheters. We don't have it, so this is our first case. We didn't know what the necessary equipments are, so please bear with us during the case. And I asked Dr. Simon also to bear with us because we have only the renal double curve guiding catheter. I hope it will be fine, but this is not the usual way that Dr. Simon works. He works mainly with the Lima, and if it doesn't work or if there is an acute angle or something, then he starts to think about other alternatives. So the first thing we'll do next is to buy a lot of Lima renal catheters, right? All right.
So the usual takeoff of the renal arteries is at the disc space between L1 and L2.
Is this the proper site to do the injection? At the screen?
Well, we can double check before.
Yeah, just قبل ما تدي.
There's a great deal of anatomical variation, and that's the other reason that the aortogram is useful.
I think the left renal doesn't look that well. Do you need other angulations or
No,
it's a bit curved?
It'll be okay. It looks like a fairly standard. Can we freeze frame on the aortogram? They look very standard in that there's a reasonably horizontal takeoff, and then there's some upsloping at the mid portion of the renal arteries on both sides. And that sloping of the renal artery is actually useful to allow the catheter to come into contact with the vessel.
Okay, to fit well to the wall, huh?
When we come to do the more proximal burns towards the ostium of between the vessel and the aorta, we may angle the camera slightly, 10 or 15 degrees of LAO for the left.
For the left and 10 for the lateral RAO for the right.
Right.
ده مهم الانجكشن لازم يبقى في الليفت كورونري الليفت رينال تاخد شالو LAO وفي الرايت رينال تاخد شالو RAO 15 10 15 عشان تقدر تشوف التيك اوف بتاع الاوستيوم جاي فين بالظبط بتاع رينال ارتري. العيان ده الحقيقه والسوتابل لان زي ما انتم شايفين اتس لونج renal artery والبايفوركيشن فار من الاورطه and at the same time مفيش سايد برانشز كتيره طالعه من المين renal artery. sometimes البرانشز دي بتبقى معوق في الابليشن.
دكتور عادل.
أيوة.
You consider the presence of an accessory renal artery a contraindication for the procedure?
لا it's not but it might hinder the response. لما تيجي تعمل